My name is Roberta Ladenheim. I'm a visiting researcher this month in October here in Deusto International Training Academy. The title of the presentation is Medical Educators' Conceptions about Generic Competencies in Argentina, and the idea is to give contribution for consensus building in the healthcare professions education, and I've done this research in collaboration with Cecilia Hernandez. I want to introduce myself. I'm a physician, specialist in internal medicine. I also specialized in healthcare professionals education. I belong to an institution called CEMIC, founded in the year 1958, with the idea that through research and medical education, we can improve patient care. This is the institution, and I'm working there in our university institute as a director of career of medicine. A quick overview of the presentation. For matters of time, I will only have a little moment to talk about challenges in medical education nowadays and the context of medical training in Argentina, a little bit about the theoretical framework selected for this presentation, our leading research questions, what we did and what we did it, and where we think we can go on from now. About challenges in medical education, it is said that professional education has not kept pace with the challenges, and mainly because of fragmented, outdated, and static curricula. And one of the probably causes of this situation is what is called tribalism of profession, with the tendency of the various professions to act in isolation instead of within each other. Medical education is supposed to be at a crossroads, and one of the paths to go from this place needs for us to leave the individualistic hero-doctor ideal that it's not longer necessary or proper. And this is said in this year, health profession training is not walking through the right path. We need safer systems and individual and collective competencies. And when I talk about safer systems, we are talking about people dying from medical error every year, and health communication and health teamwork, it's one of the main causes of this situation. These challenges have resulted in the introduction of non-specialty specific generic competencies that in health professional education mainly add communication skills, collaboration, understanding healthcare systems, and competency frameworks in medical education have a strong relevance in helping introduce these new generic skills into our programs. So strong that one of the ideas of the College of Physicians and Surgeons of Canada, better standards, better physicians, better care. And if we see international frameworks, we see that there's a mixture of generic and specific competencies such as professionalism, system-based practice, and medical knowledge as another competence, and the roles describe professional communicator, scholar. There's been an evolution in medical education. The paradigmatic report called Flexner report now is what we call traditional medical education. 60 years ago, we introduced outcome-based medical education with the mandatory social accountability we have in this health professional training. And 100 years after the Flexner report, one of the highest recommendation or strongest recommendation is about curriculum integration. But despite this recommendation, curricular structure in medical training in Latin America is not integrated. We're still in traditional curriculums where basic and preclinical and clinical parts or areas are divided still. Medical education is supposed to be a continuum in the world where the competencies a professional needs to go to professional practice sometimes are not all achieved in the undergraduate medical education. But in Argentina, the degree of medical doctor authorizes professional practice. And when people acquire this degree, they go into professional practice, maybe without further postgraduate specializations. And postgraduate specialization can be done in university and non-university institutions, public and private, and it's regulated both by Ministry of Education and of Health. So the field for health human resources training in our country is complex, mainly because we have both regulations by National Ministry of Education and National Ministry of Health, but remember we also have a federal republic with local governments with strong power, and people are training in the higher education system, for example, by doing like a specialization career, and in the medical residencies in the health system. And these both systems doesn't have the same logic and are regulated by different entities. A little bit about the theoretical frameworks. There are debates in competence-based medical education nowadays. First, it's said that there's not an only definition of competence, and this might have implications on planning and teacher performance. Competence-based education is called to be reductionist. It's criticized because of its reductionist, making a checklist only of activities to be performed, but sometimes reductionist is necessary, for example, for planning or assessment. There's a need for an individual competence, but also a collective competence. That is an idea we're talking lots in medical education, and sometimes maybe the individual competence that doesn't secure collective competencies. There are some non-observable aspects of professional practices with strong relevance, for example, empathy or medical humanism, and what I will talk about later, generic and specific competencies. And all these visions might have a place in medical education, but the issue might be when and how to apply these visions instead of in a dichotomical way, maybe in a more inclusive way. Curricular reform is a complex and challenging situation, and that's maybe one of the reasons we still are in traditional education with external influences, organizational influences that in our case respond to the logic of university and hospital also, and internal influences being teachers and planners conceptions, one of the influences to be looked at. And it's been said that we are like captive on a carousel, and instead of really innovating, we're going around the same problems and not giving them a different answer. A little bit about the relevance of sharing a language and the idea that this paradigm shift we are about to do is like an adaptive change, and it needs a shared language to be done. Ambiguity around the language of competence-based medical education has been highlighted as an important barrier to the adoption of a new paradigm in several publications. And getting into the subject of generic competencies, Tuning Project describes two sets of competence, generic one, which could be general to any degree, and specific ones, which are those subjects area related. Then constant changes has led to success in the labor market being related to these generic competencies, and the context determines the generic competence to include in our framework list in each region or country, and the way to present them in semantic terms for the people to have a shared knowledge and context. There are many terms to refer to generic competencies: key, transversal, cross-curricular, core, soft. Medical educator calls them domain independent. And last year, 2016, la Sociedad Española de Educación Médica referred to them as orphan competencies and a strong deficit in healthcare professional educations. But this distinction between generic and specific might have difficulties and might have some issues to be addressed. For example, the example of Tuning Latin America in the area of medicine, where the group started working the generic competencies, communication, they decided it was a specific one. They didn't want to treat communication only as a generic competence because they thought communication in medicine has particular precise things. So the idea is, in practice, generic competence do not seem to be rigidly separated from a specific competence. That's an idea about the difficulties of implementing this distinction. A little bit about the research background for this particular research. First, official documents in Argentina have different ways of including generic competence. Till the year 2013, nobody talked about generic competence in documents, and the first time it was mentioned, it was by Ministry of Health with the term transversal contents. The second one is that generic competencies are included for us as accreditation standards for medical residency, but it's not clear how to do it because it's not there in the documents how to develop them. And then we did some special research when we did an analysis of the information in one of the reference frameworks, internal medicine one, and we saw in the document that there are two separate blocks, one dedicated to discipline and one dedicated to the transversal contents. So we were asking ourselves, educational planners in Argentina have different conceptions of what generic competencies are, and this heterogeneity in references in the frameworks respond or relate to these different conceptions. That's why this is the leading research question. What are medical educational planners and policymakers' conceptions regarding generic competencies in Argentina? And for this, why explore conceptions, something we've been talking a lot. Conceptions are beliefs or ideas that function as lenses through which people view and interpret the world. They may act as cognitive filters and they influence teaching, performance, planning, assessment. So the relevance conceptions have impact on curriculum planning. They are useful for understanding complex scenarios with many actors involved, such as our own. Planners may act as agents for change and curricular reform, or maybe as resistance to it. Possibility to construct from teachers' previous knowledge instead of imposing something different and necessary for consensus building. But there are also difficulties when dealing with conceptions because they are dynamic, influenced by context and social phenomena, must be inferred because they are only partially conscious in teachers, and they are not the only factor obviously influencing curriculum planning. So the objective was to explore educational planners' conception regarding generic competence in Argentina. We did a qualitative exploratory study with semi-structured interviews. The sample criteria, we decided to work only with medical education experts, meaning expert whoever had a specialization or acknowledged trajectory in the area, and with people linked to planning, current or past involvement in curriculum planning and policy making, people from ministries, frameworks, and policies, and people from the university, authority, and program director or coordinator. The interviews were done all by myself, all were recorded and transcribed, and they were all in Spanish language, obviously, and the number of interviews was defined by theoretical saturation criteria, and then we did an initial analysis to build the categories for the analysis, and independent analysis conducted by both researchers to minimize the subjectivity of myself having done the interviews. And we decided to do a triangulation with documents available, with a revision of documents available. The interview protocol is long, but it explores definitions and terms, history, educational planning, teaching and learning of generic competencies, and assessment of generic competencies. The first question was, what do you think generic competencies are? How do you define? And to give the opinion about the different terms. The categories. For this presentation, we will only show results of definition of competence and generic competencies and the specific generic relation and advantages and disadvantages according to doing this separation or not. The rest will be for further work. We did 12 interviews. Interviews lasted between 26 and 86 minutes. 8 were female. It's described a feminization process in medical in Argentina, with 70% of females being the field, so it's representative at that point. 8 physicians and 4 came from educational sciences. 11 had involvement in undergraduate medical education, 10 in postgraduate medical education. 7 had participated in building reference frameworks or policies in ministerial policies. 5 public, 7 private. We have more private medical careers in Argentina than public. And 6 has active participation in the health system. As you can see, people develop or perform different tasks at the same time and have different roles. Okay, a little bit about the results. I will present some ideas and some quotes about the definition of competence or linked competence to professional performance in a certain area. They involve a located and contextualized side and can't be regarded in abstract. They think competence to be an useful construct or model helping practice to be operative despite some implied learning fragmentation, and they believe observable matters allow planning and assessment. Models are viewed as means to approaching the complex, yet there are partial views leaving other sides blind, and the term competence itself is viewed as travel leading outcomes rather than competence might be mentioned. And one of the quotes we selected, speaking about competencies would be like denaturalizing some part of the educational phenomena, the social phenomena. When it comes to practice, you see the need for competencies. It is a very useful construct, but I perceive it as rather limited, failing to embody other issues I find relevant. Or the other one, sometimes I'd rather not use the word competence and say, what outcomes are you thinking? What are you expecting to? About the definition of generic competencies, everyone manifested difficulties in finding a precise definition of what generic competence is. They agree generic competencies to be those which go across different specialties, but not mainly different professions. They refer to different specialties in health professionals mainly, and generic competencies are those everyone should have depending on each profession. Some might require further development. So, generic competencies are hard to denominate, to delimit, they're slippery, they run the risk of being confused with good manners or good practice or doing the proper thing. And some words that came, core, basal, long-lasting, some sub-competencies, transversal, general, generic attributes, generic values. And another one, I see them as transversal to different professions. They go across the different fields of work in varying degrees. If you think of different workplaces, then competencies are transversal to all of them, yet in different professions or places you need some more than other. Generic competencies are necessary for any profession. About the definition, they believe generic competencies are context dependent. Most of the interviews, some believe there are like generic competencies and then generic proper to medicine, for example, and they are linked by many interviews to humanistic domains, social in general, exceeding the technical intervention itself and going beyond what is unique and specific to a professional area or discipline. Generic competencies are all those that aid towards the effort coming together in processes that are beneficial to people they work with, people they work for, and for the community, making that specific competence result in a positive, beneficial outcomes. Oh, another one thing is for sure, there are generic competencies that are unique to some professions and become specific. That was the idea of tuning medicine communication. There were tensions manifested regarding the term generic competence. Most of them think there's a tension with the terminology, like a conceptual cross between generic and competence. It's a certain lack of consistency, as competence for us is expressed as a whole, and by generating a category that names them as generic, a differentiation or dissociation is generated. And for some, competencies involve itself some specificity. Indeed, the point is, if you create a category, then you're already stating that it's different. It's in fact, it's a part of your performance. You can't split it. You don't first learn anatomy and then generic skills. That was one quote, and the other one, some difficulty with generic and the competencies issue, as far as competencies have a located question and a contextual question and a specificity. I think there's a crossing in terms of what's generic and what's a competence. I find there's a certain difficulty in linking generic and competence in one term. Competencies are defined as a whole, therefore, what is the generic part within that whole? That's namely a specific competence. And about the generic-specific distinction or relation, most interviews consider generic competencies learning to be regarded within discipline and practice. In their view, a competent action or a competence does involve both something generic and something specific, taking place within the context. They are linked in action, they actually coexist. Competence is one in action, and the generic-specific division results from utilitarian enunciation purposes to understand a highly complex issue. And the quote, I think there's only one competence, and there are activities where professionals showcase their competencies. I think if you keep this in mind, then any model, whether generic or specific, will be a valid model as long as you consider that if you paint generic green and specific blue, the overlapping spot will be where the competence really is, not either on one side or the other. And the last one from results, interviews agree that generic competence must be visible in curriculum for practical purposes, but that attention must be paid to the way they are enunciated and risks are implied in enunciation. Intent statements might be void, might be presented as complementary, might not be viewed as part of something more comprehensive or integrated as professional practice, and might be taken as optional. First, I think everything needs to be enunciated, what you pursue as essential. The way it is enunciated is crucial as it might lead to interpretation. What is not enunciated, what is not objectively stated, what cannot be approached concretely and formally from education, eventually turns up from a different side. And the other one, a positive discrimination concept might be used. If we fail to talk about it, we risk not placing them in training, not taking them into account. So we need to enunciate them in order to get rid of this notion that the only competence that is specific for a discipline is valid. If you place them there, then we're like saying, keep in mind you need to work on this. So I think that's their practical use, not to make them lose visibility. And the last one, if I fail to include it, then it will get lost. If I include it in isolation, then it becomes banal. As a synthesis of results, there are some difficulties with the term competence, difficulty with definition of generic competence, but they agree that they are relevant in training, go across different health team specialties mainly, exceed technical intervention, are context dependent, everyone should have them depending on each profession, some might require further development. There's a lack of agreement with the way of denominating generic competence. There is some relevance of making generic competence visible in documents, and enunciation matters and implies potential risks. So as I told you before, for us, the starting point was the fact that in Argentina, documents and frameworks and accreditation process has an heterogeneity in references of generic competence. So we wanted to explore the conceptions behind these documents with the semi-structured interviews. We did the synthesis of the main conceptions. And with that, we constructed a lecture key based on conceptions to do the review of the main documents. It's complex, and I won't go into detail, but there are the main document regulating undergraduate medical education. Learning outcomes are expressed as competencies. Generic competencies are not mentioned, and no term is used to refer to them, but they are included in professional activities that include generic and specific. And the other, this is a guide that is presented by Ministry of Health to elaborate frameworks, and that's the first time they introduced the term, but with this coexistence of competencies and block, and in that guide they use the term general to refer to other things, so there's like a confusion in that. So for this to make it clear, about the conceptions and the possible relation with the documents, in conception, there's resistance to using the term competencies, and not all documents make a definition of competence explicit. There is general agreement on conceptions on what generic competencies are, though lack of precise definition, and we can see that documents evidence a lack of consistency to name generic or not to name it, and how to name it. Generic competence goes across different health professions in conception of medical planners, and in the guide they are mentioned as transversal to health team specialties, or like a coincidence. They are context dependent, and they appear in the guide related to professional activities, and there's a relevance of making them visible, but with difficulty with the term generic competence, like a meaning it's like a construct under construction still, and they're included, but not all documents name them. And there's use in the conception of multiple or different denominations, what is also seen in the documents. Also, in the results, we wanted to show some quotes referring to the process of change, of introduction of generic competencies, and these are results that they're only preliminary. Actually, the process evolved with the growth of health science careers, research in medical education, with increasing acceptance of contribution from other disciplines in the health science area. Teaching team, which our case answered to two logics, healthcare system and the educational system, the former not always prone to change. And once you finish medical career, the discipline matrix is so strong that deconstructing it, being able to work with generic competencies would require double effort. It's a major challenge. I believe it's being increasingly considered an approach. And finally, I believe one of the main change drivers is thinking you can improve what you're doing. But there are high stakes favoring their feuds. Let's say no one is willing to risk their power, so it's hard to budge in such a structure. Change is unlikely, and I believe these are hard roads to treat since power stands in the middle. Any cross-cutting process would involve yielding power. When you cross-cut your yield power, you're surrendering a piece of your lot. Interdiscipline is yielding power. We have some concerns about the methodology. Was the interview protocol adequate to explore in depth the objective or not? Was the sampling correctly delimited and justified? Should other actors that participate in health resources building should be included, for example, actors that are not medical education experts? Is the theoretical framework the best for showing the relevant theories and concepts? Should we do an interview analysis for contradictions? That is something that appears when we read it. Should we conduct a document analysis of national regulatory instruments more in depth? And should we conduct further research on other factors that operate in curricular reform? And this is the last one. We think that from this work we have some conclusions. This locally generated data showed that medical educators in Argentina lack of precise common definition of generic competencies, revealing some difficulties with associating the terms generic, competence, and generic. And conceptions of generic competencies are those that go across different professions, but mainly they appear within health profession, not professions in general. We think our contributions for consensus is the idea that we need to build a shared language, not only of competencies, as it was said in literature, but also about generic competence. That generic specific separation might be useful for planning, but it can be viewed when we do it in separation as non-medical, soft, extra, optional, non-pertinent, and nothing relevant should be taken for granted. And we have some questions for future research. Maybe according to different planification levels, this distinction has different implications. The other one is if international synthetic frameworks that are used in other countries could be the answer for our field, and to think if these tensions about denomination might exist in other medical educators that share this concept of competence and this contradictory. We must work in finding meeting points between logics of education and healthcare. That is what our duty, and we must invest in improving really health team by lowering what is called the tribalism of professions. Bueno, muchas gracias. Ahí sí está el logo, and if you have any questions or suggestion or feedback, as this is an ongoing work, I really appreciate it.